Good evening, everybody. Thank you so much for coming. We really do appreciate it. My name is Phoebe James, and I'm a Professional Development Officer with the Hunter, New England and Central Coast Primary Health Network. I just wanted to start by acknowledging the traditional custodians of the land that we're all on today. It's been a beautiful, beautiful day on our Awabakal land, and we're very thankful for that. And pay my respect to elders past, present, and any First Nations people joining us either here or online. Just some housekeeping. There are, for the people here, the bathrooms are just out and to your right. And for the people online, please send us through your questions. We will try to answer as many as we can at the end of the presentation. And without further ado, it is my pleasure to introduce Dr. Michelle Redford, General Practitioner and GP Primary and Integrated Care Advisor to the Hunter, New England and Central Coast Primary Health Network. Thank you.
Thanks, Phoebe. That's great. Yes, my name's Michelle. I'm a GP in Newcastle, and I have a role at the PHN. And so I also have a kind of clinical advice role from a GP perspective within the Diabetes Alliance Programme Plus. So I'm happy to discuss those sorts of things with people. Anyway, I'm really only here for introductions, and Sham probably doesn't need much of an introduction to most of you. He's sort of a little bit famous locally now. So it's my pleasure to introduce Associate Professor Sham Acharya. He's a senior staff specialist in endocrinology and diabetes. He's the John Hunter Hospital Clinical Director of Endocrinology and Diabetes, and of course he's the clinical lead and founder of the Diabetes Alliance Programme Plus, which we're now calling DAP Plus, and that's what you'll see on all of the information that we produce. He's also a conjoint associate professor at the University of Newcastle. So I'm delighted to introduce Sham. He's going to be talking a bit about an endocrinology topic today. So the Diabetes Alliance is branching out a bit, as well as our core diabetes work, also touching on some of those topics that are creating issues for clinicians in the communities. And that's coming to light a lot through the new advice line that you may be familiar with based at the John Hunter. So it gives me great pleasure to introduce Sham, and he'll take it from here.
Thank you. Thank you, Michelle, for that kind introduction, and good evening, everyone. Thank you all for attending, and I would also like to welcome all my colleagues across on the webinar this evening. Let's get this working. So tonight's topic is about low TSH, how to investigate and manage. Primarily, I will be discussing about mild hyperthyroidism. And I would like to re-emphasize that Diabetes Alliance program is bringing specialist teams to your own practices. Please consider sending the expression of interest through the DAP Plus website. We now have a beautiful website thanks to HMRI, our partner organization. And all the details will be hosted on the website, and that serves as our primary contact point. And this beautiful artwork is created by one of our indigenous art worker, Jody Reynolds. Basically, this depicts our indigenous community. These are our First Nations people in their community, and Diabetes Alliance travels through their community offering assistance to improve their health and well-being, as well as diabetes-related outcomes. So, as Phoebe said, I would also like to pay my respect to all elders past, present, and future, not only in the Awabakal land, but also across our nation. Few more things. This is our web page. The other thing I would like to say is that there is an advice line. If you are stuck with a difficult case, and if you wanted urgent advice from the endocrinologist, there is an advice line. I would encourage that you go through the website to find the advice line number, because sometimes I don't remember what the number is. I never call that. And Health Pathway also has that number. And Dr. Dishan, who is here with us today, he is the first on call for that advice line, and he would be able to assist you. But please be kind to him. And the second thing I would like to say is that we host a series of educational events throughout the year. This year we have planned thyroid and a bit of hypertension. And towards the end of the year, Dr. Magrath, who is not only our local ultrasound specialist, but he's also recognized nationally for his contribution in thyroid ultrasound, he will be giving you direct webinar as well as face-to-face lecture discussion about thyroid ultrasound scans, because there is an epidemic of thyroid cancer being created by clinicians now by oversubscribing thyroid ultrasound scans, and we really need to be careful about why we do thyroid ultrasound scan, how do we interpret the thyroid ultrasound scan, and when do we need to do the biopsy, and how to interpret the biopsy, basically the right patient, the right scan, and the right treatment. So Dr. Magrath will go through that extensively. And I would make it a little bit of relevance today during the discussion whether we need to, when do we need to do thyroid ultrasound scan and other things. We also have two face-to-face one-day diabetes professional conference. One is in Musselbrook to be held on 1st of June, and the second one is, I think, is in Inverell. Yeah. Please refer to the web page for all the details, because that would be updated, and also you can look through the PHN. Okay, so that's the housekeeping rules. Now, most of the things what I discussed today is already mentioned in the Health Pathway website. So if you didn't remember everything, it's okay. You can always go back to Health Pathway, and the information is in the Health Pathway. My talk would be an extended version of the Health Pathway, just to make it more relevant, giving you the context. So I'm sure everybody is familiar with the Health Pathway, community health pathways. Yeah. If not, all the information is on the table as well. Okay, so tonight we are talking about low TSH, and I would touch upon a bit of introduction towards thyroid hormone, how to interpret thyroid function test, and how to recognize when things don't actually make sense. They are called as discordant TFTs. We'll also show you how thyroid function tests are actually measured in the lab, and then you will start probably losing faith on a lot of tests that you do. But that's not the intention. You need to start recognizing the limitations of our own tests. Then we go through the differential diagnosis of low TSH, including sick euthyroid, subclinical hyperthyroidism due to multinodular goitre, Graves' disease, pregnancy, drug-induced hyperthyroidism, secondary hypothyroidism, so it gets very complicated. I was talking about hyperthyroidism, and I'm already mentioning about hypothyroidism there. Subacute thyroiditis, when to request further tests, when to refer to specialists, and how to manage these conditions in specific situations. So this session is really meant to be interactive, although I can't really see people who are on the webinar, but at least I would like to interact with the audience here, and there will be series of questions and answers, and I would like you to participate as much as you want to. And at the end of the session, we would open it up for questions and answers, and Dr. Michelle Redford would be able to assist us. Okay, so we all went to medical school, and we understood where the thyroid sits. Basically, thyroid sits below this hyoid bone, and it's actually a very small gland, weighing only 10 to 20 grams, not 10 to 20 kg, okay? And it has got 7 to 10 ml by volume, if you do look at it on the ultrasound scan. So this is the thyroid below the hyoid bone, and thyroid hormones are synthesized within that thyroid gland under the influence of a hormone called TSH, secreted from anterior pituitary. In relation to that, thyroid gland then synthesizes and releases T4, otherwise known as thyroxine or triiodothyronine, or T3, otherwise known as triiodothyronine. T3 is the biologically active form in peripheral circulation, T4 gets converted into T3, and all the metabolic actions that we see or what we need comes from T3. Virtually every single cell in our body needs thyroid hormones. There is no cell in our body which doesn't need our thyroid hormone. Okay? Okay, so this is the cartoon again. This is the pituitary hormone, the anterior pituitary. This is the posterior pituitary. This is the hypothalamus. Hypothalamus secretes a hormone called TRH, which in turn tells the anterior pituitary to secrete TSH, thyroid stimulating hormone. And TSH then tells the thyroid to produce T4 and a little bit of T3. And in peripheral circulation, T4 gets converted into T3. They go through the liver, skeletal muscle, cardiac muscle, and various organs, including the brain. And then they get circulated, and they get deiodination happens, and the material gets reabsorbed, and there is a bit, it goes in the enterohepatic circulation. And T3 and T4 also feed back the brain to say that we are doing our job, so now you can set back a little bit. So then the TRH dampens, TSH dampens. So in health, everything is in equilibrium. You don't know these things exist. Our patients don't know these things exist. Only when things go wrong, of course, we start noticing them. Okay. This is a little bit more complicated. This is probably the most complicated slide, and past this, it will become easier. Okay? I'm just trying to remind everybody the physiology, the biosynthesis of thyroid hormones. Now, what's the most common ingredient or most important ingredient for thyroid hormone? Iodine. Perfect. Iodine. Okay? So as soon as you take iodine, iodine gets absorbed, it goes into the thyroid. There is a key gatekeeper called sodium iodide transporter enzyme, which allows the iodine to be trapped inside the thyroid and into the follicular cells. With the iodine and tyrosine, the amino acid, you combine them and you start getting this monoiodothyronine, diiodothyronine, and the thyroglobulin matrix. There's a series of enzymes involved in that. One is peroxidase enzyme. You heard this peroxidase enzyme? That's what you measure day and night, TPO antibodies. Constantly everybody gets thyroid peroxidase antibodies day and night, and that's the enzyme. That's where it is. You can see that, right? Very important enzyme in the synthesis of thyroid hormone. And iodine basically gets oxidized to do this entity, and then again peroxidase comes, and then by further oxidation, you get thyroid hormones, and it cleaves off from the thyroglobulin, and in relation to metabolic demand, thyroxine comes out of the thyroid and goes into the periphery and starts converting itself into T3. And then there is one more step, which T3 gets converted into reverse T3, but please do not ever ask for reverse T3. It has no value in terms of analyzing, because I see all these tests done, and patients come to us, my reverse T3 is high. But who asked you to check it, right? So do not do tests which have no value. So there is reverse T3, you can ask for it, but we can't interpret it, how to interpret it. So do not ask that reverse T3. So basically that's how our body handles everything. And now you remember, antibody against peroxidase enzyme is TPO antibody. Basically what it does, it blocks the synthesis of thyroid hormone, so you get Hashimoto's hypothyroidism. Easy? Everybody understands that? Yeah. Now when we talk about TRAB, TSH receptor antibody, we also include 2 or 3 types of antibodies in that whole package. One of them is called TSI antibody. Is it getting too complicated? No. So TRAB includes TSI. TSI is thyroid stimulating immunoglobulin. Basically that one doesn't actually block the enzymes. Basically this is very similar to TSH. So this TSI antibody mimics TSH, goes and occupies the receptors, and thyroid thinks, okay, TSH has come, I need to start producing more. So it starts producing more and more thyroid hormones, and that becomes Graves' disease. Okay? In that TRAB antibody, there is also a blocking antibody. Sometimes people with Graves' disease, They keep switching between overactive phase and underactive phase. And that is because the TRAB sometimes has blocking antibody, whereas TSI is a stimulating antibody. When we measure TRAB, we measure both of them. And there is also a neutral antibody. We measure all of them. But TSI is a very specific one. So it's more specific for stimulating Graves' disease. Okay. And this TSI also causes Graves' ophthalmopathy because it goes and starts attacking the orbital fibroblasts, which in turn start secreting glycosaminoglycans and all those things which causes edema and swelling. Now, I mentioned earlier thyroid hormones. Iodine is the raw material, and most of the activity comes from T3, but a lot of activity also comes from T4, and it is involved in regulation of the cardiac function, basal metabolic rate, oxygen consumption, thermogenesis, glucose, protein, fat, lipid metabolism, fetal growth and development, very important, thyroid hormones, bone management. Excess of thyroid hormones can result in osteoporosis. Wakefulness, alertness. If you see somebody with the myxedema status, they don't have wakefulness because they don't have the thyroid hormones to keep them awake. It's also important for reproductive system and fertility. And in extreme severe hyperthyroidism, you tend to get amenorrhea. Remember this. In severe hyperthyroidism, you tend to get amenorrhea. In severe hypothyroidism, you get menorrhagia, and not the other way. Because I get all these questions asked from the patients. My GP told me that it is my thyroid doing this. It's not. It may be fibroid that is causing you to have menorrhagia in hyperthyroidism. It should be the other way. Okay? And thyroid hormones are also required for renal clearance and GFR. Sometimes there can be fluctuation in the GFR, primarily based on how high thyroid hormones are or how low the thyroid hormones are. Okay. Now let's move into clinical pictures. Iodine, everyone should know this, but we don't take any notice of iodine because Australia is now iodine replete country. There is iodine in all our iodized salt and everything, so we don't really take any notice. But if you are born 50 years ago, or if you are practicing medicine 50 years ago, I should say, that would be a different story, okay? And these are the daily iodine requirement, 90 micrograms for children under the age of 8, 120 between 9 to 13. Most adults would require 150 micrograms of iodine. 220 micrograms for pregnant women, and therefore we recommend them to have that supplement. And during lactation, the requirement is even higher, 290 micrograms. This is from the WHO. So what are the primary food sources? Well, iodized salt should give you plenty of iodine. Bread is also iodized, so is milk, because the way the milk is pasteurized, you will get enough iodine in the diet. But if somebody went on seaweed diet or kelp diet, I've seen that before, they will have excess iodine ingestion and they can develop hyperthyroidism. Okay, so you need to really question that. And occasionally it's typically some of the people from China, they do tend to take kelp and some of those as the supplement. So you have to be alert into that. And the treatment is just to stop that thyroid function test go back to normal. Unfortunately, iodine deficiency is still seen in some parts of this world, which can cause a lot of problems, including goitre, big goitres. And you may see some immigrants coming from Africa, for example, and they may have goitre because they have been suffering from iodine deficiency. And long-standing iodine deficiency basically stimulates the growth of the thyroid. Ultimately, it becomes nodular, and eventually they become autonomous. They go completely out of control from the TSH, which then causes hyperthyroidism, and in extreme cases can cause thyroid cancers too. Okay? And iodine deficiency during pregnancy can result in a condition called cretinism of children. Are you aware of this word, cretinism? Yeah. Cretinism is unfortunately severe mental retardation in children, delayed milestones, and it's a sad thing to see, and still they would respond to thyroxine initiation. We don't see it that many now in any parts of this world, but when I was a medical student, I saw a lot of cretinism in India because it was slow to start with iodine supplementation back then. Now, this is the current iodine status worldwide. Now, if you see the gray color, that means it's iodine sufficient. And how do we measure iodine sufficiency is through 24-hour urine iodine measurement. And that's only done for epidemiological purposes, for public health purposes. We do not recommend you test urinary iodine on your individual patients, okay, because it's of no use at this stage, except maybe in select population, but then the interpretation becomes quite difficult. So this color, dark purple color, indicates ongoing iodine deficiency. So you see the northern hemisphere, there is quite a lot of iodine deficiency towards Russia and some parts of China. And there are certain African countries still facing iodine deficiency, and red means urinary iodine is in excess. So how did we get that? Nepal has become iodine excess. How did it happen? Anyone knows? Okay, 50 years back, Nepal was severely iodine deficient. Severely means severely. Goitre was 50% prevalent in population. So Nepalese government started iodine supplementation. They had a mass iodine capsule and iodine injection program to the population. And they've done well to eliminate iodine deficiency, only to replace this with excess iodine. Right. Now what happens in Nepal with the excess iodine? Unfortunately, they have hyperthyroidism affecting 25% of their population because they all have goitres. And when you have nodular goiter, you give excess iodine, of course it's going to turn into hyperthyroidism. Okay? So you understand the concept now, iodine deficiency, structural changes in the thyroid, and when iodine excess happens, it will become hyperthyroid. This is a non-autoimmune hyperthyroidism. Okay, good. And pregnancy, iodine is very important because iodine deficiency, in addition to cretinism, can actually cause recurrent miscarriages and stillbirth. Okay, we discussed everything else earlier. Okay. Having said that, we use a lot of iodine in the medicine as well, don't we? Everybody is familiar with amiodarone. Each tablet, 200 milligram tablets, gives you 6,000 micrograms of iodine. And how many years do your patients take amiodarone tablets? They've been on 200 milligram 3 times a day for several weeks as a loading dose, and then get 200 milligram once a day for several months to years. Do you check their thyroid function tests? You should be. Anyone on amiodarone, you must be checking thyroid function tests, at least at the beginning, then maybe 3 months, then 6 monthly, because delayed amiodarone induced hypo and hyperthyroidism still happens. I will explain to you in a case later. Now, CT contrast, everyone writes CT contrast. All of us write CT contrast, right? Now, think about the iodine content of CT contrast, 300 milligram of iodine per ml. Typical scan has 50 to 100 ml. That means 15 to 30 grams of iodine. And that's the microgram. I had to use calculator, obviously. But then why don't we see so many hyperthyroidism? Endocrinologists should be very rich. They should be seeing all this, right? Hyperthyroidism. Why don't we see? Because there is something called, in a healthy thyroid, I told you about sodium iodine transporter enzyme as well as peroxidase enzyme. They are very clever. As soon as too much iodine comes into the thyroid, they shut the gate. They shut the gate and say, no more, we have plenty, this will kill us, go away. And it all goes down in the urine over several weeks. But in people with nodular goiter, such protective gates are lost. So it would just soak up whatever you keep giving the thyroid. It will eventually turn into hyperthyroidism and can be a very bad thing to manage in these patients. Okay, this is Wolff-Chaikoff effect, where there is a healthy thyroid auto-regulating the iodine incorporation, and the escape of that effect is called Jod-Basedow effect. Nobody needs to remember except Dishan. Sorry, Dishan. Okay, now how are TFTs tested? Well, we did not have T4, T3 for a long time. It's only in 1970s onwards we started getting immunoassays. Before that, we had TSH. Even before that, you just measured the pulse rate and decided this person had overactive thyroid. When I was a medical student, my job was to go in the middle of the night, check pulses on my patients, and document in the records. That is called sleeping pulse rate. You remember the Sham? Sleeping pulse rate. You remember that? We didn't have T4, T3 back then. Okay? But now we have T4, T3 thanks to immunoassays. So before we introduced free T4 and free T3, we used to measure total thyroid hormones, total T4 and total T3. Now, what is total and what is free? Thyroid hormones actually occupy or sit on a carrier protein called thyroxine binding globulin. So thyroid hormone plus that thyroxine binding globulin together is measured as total T4. Okay? Now, unfortunately, this thyroxine binding globulin can go up and down in various situations, including oral contraceptive pill and so many other things. So the measurements were all over the place. So it's not really reliable. So therefore, we don't measure that. But in some parts of the world, they still measure total T4 and T3. Then you have to really work it out. What's the underlying problem? So let's not worry about it in Australia. So because we are lucky here. Free T4 and free T3 are measured free from the binding globulin, so there is no interference from the binding globulin. But it is actually quite a difficult thing to get. It has got its technical difficulties in the lab. It has to be standardized. You have to constantly kind of adjust the reference ranges. And there is something called heterophile antibody interference, which I will explain in the next slide. That means what you get is sometimes you get false positive, sometimes same results you run in a different lab, in a different platform, you get a different result. So what you see may not always be the right result. As long as you can understand that, you got to take the clinical context. You have to really rely upon the TSH because that's a good measurement in most patients except in pituitary patients. Okay? TSH. And then you adjust the T4, T3 and see whether it makes sense or not. So this is the immunoassay. My colleague Dr. Lu cleverly did these slides. I thank her for that. So how do we measure most of the hormones? Most of the hormones are measured on immunoassay. Okay? That's the analyte of interest. Let's say that's the T4. You need two types of antibody to capture at both ends, head and tail, to hold that person straight. Okay? One is called a capture antibody. Second one is called a signal antibody. Okay. Now let's see. This is the patient serum. Okay. Now blood has come. There is a capture antibody, and there is a free T4. It goes and attaches itself to the capture antibody. We need the signal antibody. Now what happens? The signal antibody goes. Now T4 and both antibodies are all together. Now we measure that. You get the right result, and that is true positive. So your free T4 is reading 25. We have no problem. It's 25. Correct. Okay. Now sometime what happens? You have a false positive. So what happens? You have a capture antibody and a signal antibody, and there is some other antibody, third party. Usually it's a mouse antibody. Everybody is exposed to mouse, right? We all have antibodies, small portions, but some of us have more antibodies. Maybe they keep mouse as the pet, I don't know. What it does, it goes and occupies that testing platform. So there is nothing there in between, and basically, one step, it went too fast, sorry. T4 cannot occupy. You are actually measuring something else in the blood as T4 because both sites are occupied. So you have a false positive. It's actually getting less and less of a problem now, but we always have to make sense. Okay, is this making sense? If it is not making sense, let me ring the lab and ask them to rerun it. They are quite helpful. They don't know the clinical picture, and they will run it in a different platform and get you back the right result. Okay, false negative. Sorry, I got one, went too fast. No, that was bad. No, I think I went too fast. Sorry about that. Okay, right. Okay. False negative result means you are not able to measure the T4 because something else is occupying. So basically you understand the concept. I think that we'll leave it there. Okay. Now let's talk about clinical scenarios. A well healthy person has a normal TSH, has a normal T4 and has normal T3. If the TSH is normal, generally speaking, you do not test T4, T3 unless you suspect pituitary problem. I will make it probably clearer later on. Okay? So that's the common concept to get it right first. And then this side, deficiency of thyroid hormones is called hypothyroidism. Deficiency of thyroid hormone. So what the body does, if it is thyroid failure, because you can't get enough thyroxine, pituitary increases the TSH. So your TSH goes up, T4, T3 are low. That is primary hypothyroidism. But if the pituitary is at fault, there is no TSH coming through. So you have low TSH or normal TSH, but low T4, T3. That is called secondary hypothyroidism. You have primary hypothyroidism and secondary hypothyroidism. Everyone follows that now? Or is it too difficult? Should be good, yeah? Okay. Now, on this side, excess of thyroid hormone results in hyperthyroidism, opposite to hypothyroidism, okay? Now, again, hyperthyroidism can be primary, Graves' disease or multinodular goitre. You have too much thyroid hormones coming, therefore the TSH is switching off. That's the typical pattern you see. But rarely you see too much TSH coming from the pituitary, and then you have too much T4, T3 coming, and that is called TSH-oma, pituitary tumor that is secreting TSH. Very rare. We probably have about 5 to 7 cases in our department in the last 15 years. Very rare. But we need to be aware of that, okay? Now, in the middle we have normal, but what as GPs you see most commonly is subclinical hypothyroidism. That means TSH is a little bit high, but T4, T3 are normal. Okay? Then on this side you have subclinical hyperthyroidism. That means TSH is low, but T4, T3 are normal. They are always mirroring each other, opposite. Okay? Now let's see. Then there are many other conditions in between. They are called sick euthyroid condition, discordant TFTs, as I said before, assay interference, sometimes the drug, and rarely there is something called thyroid hormone resistance syndrome. That means the TSH comes down, but body doesn't respond to TSH. How crazy is that? So your T4, T3 are higher to attempt to respond to that. Okay? And then you have a lot of genetic conditions which cause problems with peripheral conversion of T4 to T3, and these are typically children born with some form of dysmorphism, and they have some form of difficult to identify and difficult to treat hypothyroidism. It really needs expertise to talk about that. Okay. Now once that concept is clear, this is a little complicated, but anyway, this is our bread and butter, so we should really follow this, okay? Let us say these are the reference ranges. It differs from lab to lab. Why does the reference range differ from lab to lab? Because that's the kit they have got. They have got this company kit, and they have done some validation study, and they put this as a reference range. Next month, they change that kit, go to a different kit, they have to adjust their reference range again. So this is the reference range I have chosen. It doesn't mean that it is the right reference range across Douglas or across Laverty or Pathology North. They are all different. Now, in the euthyroid state, normal TSH, normal T4, normal T3. Primary hypothyroidism, high TSH, low T4, low T3. Mild primary hypothyroidism, you may have high TSH but normal T4, T3. And pituitary hormone deficiency, you may see normal TSH, normal means normal in the reference range, but T4 and T3 could be very low. So we don't want to miss that. Can be life-threatening. But hyperthyroidism, TSH is low or 0, and typically you will see very high T4, T3. That's Graves' disease or toxic multinodular goiter. But in subclinical hyperthyroidism, you may not see very high T4, T3. You actually see them in the normal range, but TSH is low. And as I said with the TSHoma, you may have unsuppressed TSH, but high T4, high T3. Okay. Now, tonight's topic is mostly focused on subclinical hyperthyroidism. I'm not going to be able to talk about hypothyroidism today because that's itself is a separate discussion. Okay. Now, subclinical hypothyroidism is often used when the TSH is elevated, but thyroid hormones are in the normal range. Again, subclinical hyperthyroidism is often used when TSH is below the reference range, but free thyroid hormones are in the normal range. Everyone follow this concept now? Okay, thank you. Right, let's go with the case then. You followed the concept, you got to give me the answers. Perfect. Okay, a 70-year-old gentleman was discharged from John Hunter Hospital, let us say, after he was admitted with pneumonia. Okay, and he made a good recovery. They did a good job on him. Discharge letter says he has abnormal thyroid function test and GP to follow this up. Okay? His TSH was 0.25, but they didn't really get to T4, T3 because they're all measured in different assays. You remember, it's not automated that once you put the TSH, T4, T3 comes. They're all individual platforms, so they didn't do that. His past medical history includes paroxysmal atrial fibrillation, COPD, and hypertension. He is on appropriate therapy for those conditions: metoprolol, apixaban, atorvastatin, candesartan. Okay, remember that. Okay. Now you have to help me to decide. He has low TSH. First statement: low TSH is of no consequence, and therefore I do not wish to waste my time. It's okay to raise your hands. Yeah, go for it. I would go with that statement, right? No? Okay. Second statement: low TSH must always be treated as the TSH is outside the reference range. No, sure, no. I will order thyroid ultrasound scan. Nobody, you sure? That's the commonest test you order, thyroid ultrasound scan. If I have convinced you not to order on this case, I think I've done my job. Okay, differential diagnosis of his presentation includes sick thyroid, sick euthyroid. Yeah? Perfect. Excellent. Okay, very good. I'm happy with that. What is sick euthyroid? Okay, welcome to endocrinology. It's the only specialty which has terms like this, sick and euthyroid. Right? Which other specialty has conditions like pseudo hyperparathyroidism? Do you know what that is? Pseudo hyperparathyroidism? Yeah, short for, yeah. It's PTH resistant syndromes. Anyway, I won't talk about it today. So sick euthyroid is a difficult condition to diagnose, and of course there is no treatment for that. So sick euthyroid, otherwise known as euthyroid sick syndrome, otherwise known as non-thyroidal illness. Okay, so it's often used to describe a condition where during intercurrent illness, your TSH goes down, so is your T4, T3, and peripheral conversion of T4 to T3, everything seems to go down. And without any treatment, they will recover 4 to 6 weeks time, or in 2 months time, they will have no problem. But these patients do not actually exhibit hypothyroidism at cellular level. And giving them thyroxine makes no difference. In fact, it is recommended against. Okay? In ICU, sometimes they try to give treatment, but absolutely there is no evidence of benefit. So we tell them not to treat it and just sit tight. But then how do we differentiate between sick euthyroid and someone who has genuinely secondary hypothyroidism or a pituitary hormone deficiency? And that's the time you should do a cortisol. Because remember, when during critical illness, pituitary gland puts a brake on everything. It does not wish you to go and reproduce. So no LH, FSH, no testosterone at the time. Okay, everything goes down except ACTH, which then stimulates the adrenals to produce cortisol. So only hormone that goes up during critical illness is cortisol. Everything else dampens down. And that is intentional. Body is trying to kind of conserve the energy. Okay? So non-thyroidal illness, the way to differentiate is that we might help you to do that by doing a cortisol and interpreting the results. And if somebody is in ICU, they should really have cortisol more than 400. If the cortisol is like range is 110 to 550, it should be really more than 400. And if their cortisol is 150, we are in trouble. We would supplement the cortisol first, and then we might have to consider that as a secondary hypothyroidism. Okay, non-thyroidal illness typically has low TSH, low or normal T4, and usually low T3. And spontaneous recovery happens in 6 weeks without treatment. So our index case had pneumonia. He had low TSH, but we don't know whether he had low T4 or T3 because that wasn't done. Now, does he have sick euthyroid, or does he actually have subclinical hyperthyroidism? You can't do a cortisol. He's out of the hospital now. What do you do? Okay, as GPs, you have something which we don't really get. Okay, you have ability to look through his old records. It's all in your system. Okay, let's have a look at his old thyroid function test. Now, current one is 0.2. You did a T4, which is 15, T3, which is 5.3. He had low TSH going back 3 years. Okay, his T4 is usually 14 to 15, and T3 is towards the higher end of normal. Does he have sick euthyroid now? No. So everyone is happy because you were able to look through, and he had this pattern before he even got sick. And there was another important history which we did not emphasize. What else did he have? AF, correct. So he had AF, he has been on metoprolol and apixaban, but his TSH has been low for a long time. We haven't done anything about it. And this is actually very common. Very, very common. Okay? So the diagnosis is subclinical hyperthyroidism, or you can call it as mild hyperthyroidism. Now, how common is this hyperthyroidism or subclinical hyperthyroidism? The data goes between various countries. It's always difficult to know exact. In iodine replete countries, hyperthyroidism is anywhere between 2 to 25 per 1,000 population, hyperthyroidism, including mild hyperthyroidism. Now, if you are an average general practitioner with 1,000 patients, you should have at least 20, 25 patients with low TSH. I think you probably have more than that because our population is getting more elderly. Okay? In iodine deplete countries, the risk is even higher because of the supplementation has happened, and I explained in Nepal they have 25% hyperthyroidism current prevalence because of iodine supplementation. And when you look at people who are above 65, people who have AF and CCF, the subclinical hyperthyroidism is even more common. Some papers quote up to 25% in hospitalized patients with AF and CCF, up to 25%, 1 in 4. But people with AF, otherwise maybe the prevalence is up to 16%. It's actually a lot more common than we think it is. Okay. Now, does it matter? That's the next question. What are the consequences of this mild hyperthyroidism? Well, there is always the risk that it could get worse, and somebody gives him a CT contrast, and I showed you how much iodine it has got, and he will have a full-blown hyperthyroidism later. That risk is always there. And even without the progression to full-blown hyperthyroidism, there is risk of atrial fibrillation, congestive cardiac failure, coronary artery disease, osteoporosis, and even dementia in elderly people. Okay? However, there is no large-scale RCT evidence to show the benefit of treatment because we haven't done those trials. Because it's a cheap medication, no company will come forward to do this longitudinal study of 5 years. Okay. Now, that's what this paper actually tries to answer. Mild hyperthyroidism and severe subclinical hyperthyroidism. Basically, what they are trying to say, TSH detectable or TSH not detectable when T4 and T3 are normal. When TSH is not detectable, all these things, associations are definite. Again, treatment, there is insufficient data. It doesn't mean that treatment is not beneficial. What it means is that it hasn't been tested through RCT evidence. Okay? Okay. I just need to park that aside and come back to what are the common causes of hyperthyroidism in general. I'm not just talking about subclinical, I'm talking about overall hyperthyroidism. One is Graves' disease. Everyone is familiar with that, and I explained the TSI and TRAB antibodies earlier. Toxic multinodular goiter, we learned it through how lack of iodine actually stimulates the thyroid to get bulky and then nodular, and all those things happen. And toxic adenoma is a part of toxic multinodular goiter. Instead of multiple nodules, you have one nodule which is responsible for this toxicity. Then there are other causes of hyperthyroidism, such as amiodarone, lithium, checkpoint inhibitors, and immunotherapy is one of the contributor now, ipilimumab, nivolumab, and that's quite a tricky condition to identify and treat. Oncologists take responsibility over identifying, and we might have to help them to treat those conditions. Tyrosine kinase inhibitors, interferon alpha, all of them can cause hyperthyroidism. Iodine we discussed, TSH secreting tumors we discussed, and this is the interesting part, hyperthyroidism due to HCG stimulation. And this is what we see in early pregnancy, okay? And rarely we may see a choriocarcinoma with severe hyperthyroidism. It's actually quite difficult to treat. We need methotrexate and we need urgent hysterectomy for those patients to save their life, because it's all from the HCG, which again stimulates the thyroid, just like TSI antibodies stimulate the thyroid. Ectopic thyroid, functional metastasis from differentiated thyroid cancer, thyroiditis. Even in patients with Hashimoto's thyroiditis, they sometimes get a transient blip, Hashitoxicosis, and then they go down. And we have painless thyroiditis, we have postpartum thyroiditis, we have separative thyroiditis, bacterial abscess in the thyroid. I actually lost one patient when I was in Scotland. Unfortunately, we couldn't save her despite made the right diagnosis, because the pus tracked down to the mediastinum. And she had a full thoracotomy, full clearance. 18 days she was in ICU. She was 28 years old. Could not save her, no matter what we did. Can be extremely dangerous condition. Sometimes we see factitious thyroiditis because people are taking illicit stuff, supplements, whatever they want to take. That can happen too. Now, next question is, how do we investigate hyperthyroidism or subclinical hyperthyroidism in general? Well, first of all, you need to conduct a clinical examination. That goes without saying. Look for tremors, any eye signs. Proptosis exophthalmos means they have got Graves' ophthalmopathy, and diagnosis is usually confirmed. Do they have diffusely enlarged thyroid, or does it feel nodular? If it is nodular, that may be toxic multinodular goiter. Is there a compressive sign? If there is an obvious goiter, you ask the patient to lift both arms up, and if their face goes really red and choked, that means it is compressing on the trachea, and they need urgent thyroidectomy to save their life. And we see probably 1 to 2 per year like that. They need intubation, difficult intubation, airlifted from wherever they are, and they got to be going to theater. Quite a difficult condition. You always look for atrial fibrillation and CCF. Ask for any fracture history, osteoporosis history, previous DEXA scan. Have they had any of those things done? Because that will all help us to judge treatment decisions. What is the overall risk for this person? Should I give treatment or not treatment? And then the next step is TSI, because that's a non-invasive blood test. You can do a TSI antibody, and if the antibody is elevated, it's Graves' disease. Okay, TSI is elevated, not TPO. TPO does not give you the diagnosis of Graves' disease, because I told you where peroxidase enzyme acts on the synthesis of thyroid hormones. So no need to do thyroglobulin antibody, no need to do peroxidase antibody, but check TSI antibody. Done. The next step is, if TSI is elevated, it's Graves' disease. If TSI is not elevated, it's likely to be multinodular goiter. So the next preferred test is thyroid scintigraphy, technetium uptake study, not ultrasound, because ultrasound doesn't tell us anything. So you do a technetium uptake study. Technetium is biologically inert. It does not kill the thyroid. One of my patients refused to have because her GP told her that it will kill your thyroid. And I had to tell, that's a radioactive iodine. That's a completely different ball game. And technetium doesn't do any of those things. But of course, radiation contraindications still apply. If you are pregnant or if you are breastfeeding, you have to take special precautions. You will have to express the breast milk first. Generally, we don't recommend doing it for the inconvenience. So we can get the answer without doing that anyway. And ultrasound just simply confuses you unless you have a cold nodule on the scintigraphy. On the thyroid uptake study, you see a cold nodule and the radiologist mentions it's a cold nodule. Yes, then we do ultrasound and then we might do FNA. Okay? Even in cold nodule, the chances of malignancy are only 10%, not 90%. You got to understand that. Okay. And the other misconception is that I need to stop carbimazole before technetium study. You don't need to stop carbimazole. If the patient is on carbimazole, we can do the test. No problem. Okay. Remember this statement. Thyroid scintigraphy is of no use if the patient had bucket load of contrast within the last 3 months, because that iodine is going to kind of prevent any uptake. So you will have no uptake. Same thing with the amiodarone patients. They have already got too much iodine, so the contrast will not help us at all. The technetium study will not help us at all. So generally, we don't need to do that. And it doesn't mean that it's a low uptake thyroiditis and a kind of differential diagnosis all goes everywhere. So you just have to ask the patient, have you had any CT scan with contrast? And if they said, yes, I had it last month, then maybe just delay the technetium uptake study. Okay. So ultrasound, if there is photopenia, that means the tracer is not taking up there. It could be a potential cold nodule or cold nodule specifically mentioned. Or if you feel the thyroid, there is definitely a nodule, then you can do an ultrasound scan. Okay, these are some of the examples. Now this is where the thyroid should be, and we compare that with the salivary gland uptake. And this is the normal uptake, diffuse uptake, but you see this is intense uptake. That's Graves' disease. Uniform and intense uptake. What is this one then? Multinodular goitre, yeah? It's patchy, it's irregular, and its thyroid is enlarged. So it's a toxic multinodular goitre. Okay. What is this one then? This is the isthmus. Toxic adenoma. This is one single big lump that is soaking up all the technetium, and the rest of the thyroid is not lighting up. And you could beautifully treat these two conditions with the radioactive iodine therapy. Okay. And what is this one?
Post-CT scan.
Huh?
Post-CT scan.
Post-CT scan. Excellent. You got it. So don't do this test. That's what I'm trying to say. Okay. Right. Now you have got the technetium uptake study. This guy has multinodular goitre. Do we treat him or do we not treat him is the next question. So this Cooper's paper, David Cooper is a big figure in this field, and their recommendation and consensus opinion is that you look at the patient's age, somewhere around 60 plus, okay? Your threshold to treat is lot lower. Almost everybody gets treated if it is persistent abnormality. But a younger person, you would treat if the TSH is less than 0.1 or really suppressed, because their lifetime risk of osteoporosis and AF probably accumulates over decades. But if it is a 27-year-old and TSH is 0.2 to 0.3, she has no symptoms, I'm quite happy not to see her. Okay, that's okay, as long as you have excluded other things like secondary hypothyroidism and all those things. But older group, you must consider treatment if it is fully suppressed TSH, and otherwise you would still consider treatment. And again, for the reasons I explained why T4 and T3 are not robust assays, we do not put too much emphasis on T4 values or T3 values unless it is clearly elevated. Okay? Right. So treatment options. If it is Graves' disease, you may opt for 12 to 18 months course of carbimazole, because Graves' disease will have elevated antibodies, and carbimazole will help to adjust the immune system, and thereby we anticipate about 50% response rate after 12 to 18 months of carbimazole. That means 50% will relapse. But if you are a positive-minded person, you'll say, okay, my 50% of patients are treated once and for all, I will take carbimazole for 12 months. If the diagnosis is toxic multinodular goitre or toxic adenoma, because there is a structural problem in the thyroid, it's not going to go away with carbimazole. So your first line of treatment is radioiodine therapy, unless it is contraindicated. Okay? The main contraindication is pregnancy or intention to get pregnancy within the next 3 to 6 months, Or patient says, I do not want to have any radioactive iodine. Actually, radioactive iodine is a safe treatment. It does not make them lose hair. It does not make them puke. It's not like cancer radiotherapy. That's a common misconception. It's painless. They come to John Hunter, they take a drink, then they go home. That's it. Only thing is, you can't have young children around you for about 2 weeks, and you must not get pregnant for about 6 months. And it's better to kind of sleep separately for the first 5 nights if they are under 60 years of age. Nuclear medicine physicians are very good. They go through all these precautions with them. Now, if there are any compressive symptoms or signs, if there is a big nodule, it's choking on the trachea, or you decided to do the ultrasound and it showed some suspicious features on the FNA, then we would rather have thyroidectomy. Okay? But thyroidectomy comes with the risk of permanent hypoparathyroidism. Calcium controlling glands could get damaged. They could die away during the surgery, infarction. If that happens, they have to be on lots of calcium, lots of calcitriol, lots of monitoring. The risk is about, in good hands, less than 3%. But if our patient happens to be that 3%, we are in trouble. So as far as possible, it has to be thought through, and choose a high volume surgeon who has done this day and night, rather than a random surgeon who does once every 5 years or something like that. Because the recurrent laryngeal nerve is actually, you probably saw that anatomy picture, is very close to the thyroid. And if you accidentally damaged, and it could have a permanent vocal cord paralysis too. And I've seen that once. Really unfortunate. You have to have tracheostomy. So it's not an easy thing. And therefore, you could consider any of these 3 options, and of course, we are there to help you to guide that. So what's the recommendation for case 1? He has a multinodular goiter. He accepted radioiodine therapy. We discussed the pros and cons of radioiodine therapy. And once they have had radioiodine therapy, they have to have monthly thyroid function tests for about 6 months. And then 3 to 6 monthly, and then once a year. Over their lifetime, they have about 60 to 90% chance of hypothyroidism, because thyroid just dies away. So you have to remind that to the patient, and if that happens, you need to take thyroxine therapy. They have to consent to that. Typically, the dose we use is 550 megabecquerel. 60% is the published literature, and it depends on the thyroid volume. The bigger the volume, lesser the risk of hypothyroidism. Smaller the thyroid gland, higher the risk of hypothyroidism. Now, what about my nursing home patients? I mean, she's 85. She's got a bit of suppressed TSH. She's got a bit of AF, and she's losing weight. Well, low dose carbimazole therapy is an option for them long term, 2 years, 3 years, 4 years, no problem. But if you start giving somebody 30 milligrams of carbimazole, 45 milligrams of carbimazole for 5 to 10 years, that's not good, because that could cause liver toxicity, it could cause vasculitis, it could cause more serious side effects. And I've seen one person given for Graves' disease 45 milligram for 2 years without any consideration, and he developed ANCA positive vasculitis. Can be quite difficult condition to treat. It came, and that too he was given propyl thiouracil, which is not a mainstream drug to be used at all, because PTU can cause liver failure as well. So it's something we have to be very mindful. Now, the other thing is, patients with established AF need anticoagulation before we give radioiodine therapy. Otherwise, you lower the thyroid hormones, it could revert back to sinus rhythm and dislodge all the clots. And we have to, most patients with AF and hyperthyroidism need anticoagulation, because they are at a higher risk of thromboembolism. Okay, now that's clear for case 1. I got a couple more cases if you are, yes, good. Okay, 33-year-old lady, G2P1, presents after pregnancy confirmation, very early. She's 10 weeks pregnant. Some hyperemesis. I don't know why you did TSH. You did the TSH, it's 0.1. And T4 is 18 and T3 is 6. She has no goiter or eye signs. So choose the following correct actions. This is pregnancy associated hyperthyroidism. No need for any therapy apart from monitoring. Okay, one taker, half taker. Okay, she needs thyroid scintigraphy. Who would do technician scan? Nobody should do technician scan. Good. PSI. Okay, good. Okay, 1 or 2. Start PTU. No. Okay. Basically, I would choose first one because she is only 10 weeks. You could do TSI antibody. That's what a lot of specialists do because they've come to see me and I have to do something, I do a TSI antibody. Okay. But TSI antibody is only relevant in 3rd trimester because even if they had mild TSI antibody in 1st trimester, it may go away by 3rd trimester. Okay, if the TSI antibody is very high, it would allow you to monitor the patients. You may still not treat her actually, but what happens is that antibody will cross the placenta and stimulate the fetus, and fetus can get goitre and neonatal thyrotoxicosis. So you really need to get MFM team and everybody involved. But by and large, all the women we see, they just need repeat monitoring, that's all, because it will go away after a couple of weeks. Okay. In most cases, it is mild, self-limiting due to HCG stimulation, resolves by 20 weeks, no treatment needed. If it persisted beyond 20 weeks, yeah, maybe we'll consider that. And if you start using carbimazole or PTU unnecessarily in these women, and this carbimazole will also cross the placenta, and baby does not have hyperthyroidism, so baby might go underactive, right? And that's not good. And similarly, in women with Graves' disease, established Graves' disease, who are on treatment for carbimazole or PTU, when they become pregnant, you have to be mindful that you are not over-treating them to get the TSH normal. You have to let T4, T3 sit at the upper end of normal. Because we can't really trust those assays very well, it's better to aim TSH at the lower end, not normalize the TSH in Graves' disease in pregnancy, because then we will be definitely over-treating the mother. And that's the case we would be doing TSI. Now, sometimes you do see Graves' disease coming for the first time in the pregnancy, and that's where you have to look for exophthalmos, goitre, family history of Graves, past history of Graves, and of course we are happy to see those women in the joint antenatal clinic and sort them out. But we don't really need to see all mild, low TSH in the pregnancy. I think it's unnecessary. That's what I'm trying to put it across. Okay. Let's move on. Now, next case, 32, severe irritability, palpitations, headache, tiredness. She has a 3-month-old baby. She saw your partner last week, Sham, and partner said, go away, don't bother me. You have a young baby and that's why you are. But you are being very compassionate. You ordered thyroid function test because you wanted to beat your partner, right? And her TSH is suppressed, T4 is 40, T3 is 10. She has no eye signs, goitre, but she looks very fidgety, cranky, and agitated. What additional investigations needed? What is the diagnosis? What's the treatment? So we have 32, 3-month-old baby, quite hyperthyroid looking, high T4, T3. What are you worried about? Postpartum thyroiditis, beautiful. You worried about Graves, anybody? Less likely, not impossible, but less likely. Okay, if it is postpartum thyroiditis, what investigations are needed? Answer is none. Okay, what treatment? It will settle down itself, maybe beta blocker. Okay, it's okay to use propranolol if she's breastfeeding, but maybe 10 milligram twice a day is quite okay, and I get them to breastfeed the baby first and then take the tablet. Okay. Now, postpartum thyroiditis is actually quite common, generally self-limiting, and it's actually more common with those who are antibody positive. They go through this typical phase of hyperthyroid, followed by hypothyroid, and then normalization. It's a good thing that we don't check thyroid function test on all these women, otherwise we would be picking up a lot more unnecessarily, right? And we don't need to treat them with antithyroid drug because it doesn't work. It's kind of a release of all the thyroid hormones rather than increased synthesis and release. And some women may get profound hypothyroidism. Yeah. And sometimes what happens, they try to conceive at the same time. They've had a 6-month-old baby, they're hypothyroid, and pregnancy may be on the card. So that's the time you have to be a little bit careful, and I probably would treat them with thyroxine. I just ask them a question, are you really sure you're not going to get pregnant? Are you using contraception and all those things? We just monitor them 6 weekly for a couple of times until the thyroid function test normalize. And if you do happen to do a thyroid scan, it would show no uptake, but it's not needed typically. If the abnormalities persisted beyond 2 to 4 weeks, then maybe it is Graves' disease. Of course, you can do a TSI antibody, and if the antibody is positive, then it's Graves' disease, okay? In her case, TSH went up to 28 and T4 went down, but then she normalized without any treatment in 5 months' time. Okay. Case 4. 22 university student who is consulting you regarding symptoms of anxiety, which she noted while preparing for her final exams. She lost 3 kg weight, which she attributed to not paying attention to her meals. You asked her about any other symptoms, and she said some intermittent palpitations. What additional history would you take? Bearing in mind this is thyroid session. Family history, perfect. Okay. Additional history includes menstrual pattern, muscle strength, appetite, bowel frequency, any neck symptoms. Has she had any pain in the neck suggestive of subacute thyroiditis? Any family history of other autoimmune conditions? What medications is she taking? Is she taking any supplements to increase her concentration for the exam? Is she a smoker? Because smokers tend to get very bad Graves' ophthalmopathy. They must stop smoking. Okay. Okay, she hasn't had any period for 3 months, which could be because of her intense preparation, I guess, but they were regular before. She's not on any medication. She has excessive sweating and heat intolerance. Our younger brother has type 1 diabetes. Now the plot is thickening, right? Her mother is on gluten-free diet, but she didn't really ask mom, Mom, why don't you eat with us? She never asked her mom. Okay, what has she got now? Graves' disease, perfect. Okay. Her BMI is 23, she's mildly tachycardic, and neck examination shows a small enlarged thyroid, smooth and non-tender. In typical viral thyroiditis, if you happen to see them, because you might see them as GPs, they have really painful thyroid. They will not let you touch their neck. And it's thyroiditis. They might be hyperthyroid, and it responds very well to prednisolone therapy. But it takes for about 4 to 6 weeks to cut it down. She does not have any tenderness, which is good, and her eye appearance and movements are normal. So identify the incorrect statement, not the correct, incorrect statement. Differential diagnosis include toxic multinodular goitre and drug-induced hyperthyroidism. Normal TSH excludes primary hyperthyroidism. FT4 and FT3 immunoassays can be artifactually affected due to heterophile antibody interference. We talked about it. Absence of classical symptoms and a normal thyroid examination excludes Graves' hyperthyroidism. Last one, yeah? Good, because you understood. Good, thank you. Because this is our typical symptomatic patients, but in elderly patients, there is something called apathetic thyrotoxicosis. They don't exhibit any signs, but they're just withdrawn, and they just lose weight. And that can be Graves' disease as well in nursing home patients. Okay, she has T4 65, T3 30, very high. And what additional tests needed? I do not need any tests. She is likely to have Graves' disease. TSI, uptake study, ultrasound. Okay, what one thing you do not do? Ultrasound, thank you. Okay, you may need to do TSI if you are interested, but if you are confident, you could call it as Graves. I'm quite happy with that. She doesn't have any eye signs, and I would treat it. But because she comes to see me, yes, of course, I will order one, TSI. Okay, if I'm cash, if there is a recession in Australia tomorrow, we might not be able to do all these fancy tests anyway. Okay, TSI and TBI. TSI has got 97% sensitivity and 99% specificity for Graves. Very rarely you might actually see TSI negative Graves, but 97%, 99%, very good sensitivity and specificity. If it is elevated, it's definitely Graves' disease anyway. When do I do it? Well, absolute indication is for the pregnancy, and particularly second or third trimester, and I want to know whether it is a fetal association. Yeah, I would do it. And if patient has Graves' ophthalmopathy, but biochemically euthyroid, okay, sometimes I see that too, euthyroid Graves' ophthalmopathy. And that's where TSI is needed, because that would help to confirm the diagnosis. And now if you happen to do the reverse and do a technetium study for this lady who had a scan, and you really don't know whether it was scan, contrast, or Graves' disease, yeah, you do a TSI. But you can also do this for prognostication. If very high levels indicate very high risk for ophthalmopathy, and very high levels also indicate that it doesn't go away easily, it's going to take a long time. But if the low levels of titer means maybe 9 months course is enough, low dose course is enough. So it helps us to judge those things. No, not needed. That's good, because thyroid was palpable, it was not tender, it was not nodular, so I wouldn't have done that. Good. In terms of management, what are the key principles? Well, first of all, we want to restore euthyroidism and assess any complications such as AF, CCF, osteoporosis, and make sure that eyes are checked every time for any signs of ophthalmopathy. And it can be very subtle, like gritty eyes, red eyes, bit of discomfort in the eye. But if they start getting pain when they are moving their eyeballs, and if eyeballs are red and enlarged, you should really seek urgent help, because they could go blind. Graves' ophthalmopathy can be very, very horrible, and it takes several years to stabilize. And we might have to do a CT orbit and get the ophthalmologist involved, and we give them immunosuppression, and they must not smoke. Smoking is the absolute killer in this situation. And we also need to think about relapse and recurrent Graves' hyperthyroidism. We may have to consider our pregnancy plans into consideration as well. Now, how do we restore? Well, antithyroid drug, radioiodine therapy, thyroidectomy, going back to the same principle we have. In terms of antithyroid medication, we have carbimazole or propylthiouracil, but propylthiouracil is really reserved for the first 12 weeks of the pregnancy, not generally otherwise, okay? Unless somebody is really allergic to carbimazole, they come up with a big rash, you might use propylthiouracil, but there is a lot of cross-reactivity, like penicillin and cephalosporins. So 10% will cross-react, so I would be careful with that too. We may use beta blocker for the first 4 to 6 weeks, and then there are other adjunctive antithyroid drugs such as lithium, cholestyramine, maybe diltiazem, and even prednisolone, but that's a reserved basket which I would only use it in special situations. Now, carbimazole has been used for more than 50 years, and it works through its metabolite called methimazole, and basically it blocks the synthesis of thyroid hormones through peroxidase enzyme, the same enzyme, okay? And it also does the immune modulation to lower the TSI titers. PTU also prevents T4 to T3 conversion. If you happen to use PTU, maybe an added advantage. But the difference here is their half-life. Carbimazole can be taken as once a day, whereas PTU must be taken 2 to 3 times a day, because it's got a really short half-life. Okay. Now, very important as general practitioners to pay attention to counseling, because Dishan tells you carbimazole 15 milligram 3 times a day, and we will arrange her to be reviewed in whenever we can and put the phone down. You are the one who is writing the script. So what would you like to counsel the patient? Number 1, rare chance of drug rash, really red, itchy rash. If that happens, they must stop taking the medication, 1%. And risk of bone marrow suppression, this is very serious. It happens very rarely. We have had about 3 in the last 10 years, okay? So it's probably 1 in 1,000 users. But it may present, patients don't know they have bone marrow suppression. The only symptom they have is very high fever, and they may have severe sore throat. So no point in going to the GP and waiting to see the GP who is not available for next 4 weeks. So really they should go to emergency department and tell the ED doctor that they are on carbimazole, they need an urgent full blood count. If the blood count is normal, it's something else. If the blood count shows agranulocytosis, we admit them, we stop the carbimazole, we give them sometimes GCSF to stimulate the bone marrow, and we put them on neutropenic sepsis regime, and we have to really look at thyroidectomy and other things as an emergency option. Very rarely this drug can cause liver failure and vasculitis, but there is no way of predicting these rare side effects, and routine monitoring is not really helpful. They are so rare, no point in doing repeated full blood count, trying to see they are going to get bone marrow suppression or not. It's a waste of money, so not recommended. Okay? But you must document that you have had a discussion about this for your own legal purpose. Any questions? No, I'll come to the questions later. Yeah. Now, how do I choose the right dose? All the information is there on the health pathways, so I would encourage you to look at the health pathway. And we discussed PTU already. Carbimazole dose is anywhere between 5 to 45 milligram, and you need to monitor every 4 to 6 weekly and start reducing the carbimazole as the thyroid hormone levels come into normal range. And you must avoid therapeutic hypothyroidism, because that massive fluctuations between hyper and hypo can also cause Graves' ophthalmopathy worsening. Okay. Now, additional cases of hyperthyroidism may be any of these related, which we discussed earlier. Discordant TFTs. Now, when I said earlier, thyroid function tests should make sense when you see them. TSH high, T4, T3 low, clean pass. T3, T4 very high, TSH really low or suppressed, clean pass. That's concordant. Everything is agreeing to each other. But sometimes it's just all over the place. TSH high, T4, T3 high, or TSH low, T3, T4 low. So you can't really understand what's happening, and therefore we have to go through these results carefully. I'll give you some more examples and see whether you can work it out. Okay. TSH is 5.6, which is elevated. T4 is 26, which is elevated. T3 is 3.7, which is not proportional to T4, but still in the lower end of normal range. What are the possibilities? There is nothing wrong, I see, stop tricking us. Yes? Nobody for that? This is hypothyroidism. Yes? Too hard to follow. This is hyperthyroidism. I need help. Okay. You know what medication this person is on. Go back to that first principles. Take a history, look at the medication, look at the old results. Amiodarone, perfect. Okay, I'm happy that somebody said that. This is amiodarone, because amiodarone does weird things to thyroid. One of the common thing amiodarone does is it prevents the conversion of T4 to T3. So what happens, T3 is low, TSH goes up, and TSH goes up, T4 goes up, but T4 doesn't get converted very well to T3. So you have that problem, higher TSH, higher T4, and lower T3. Actually, no intervention. They are happy, you are happy, I am happy. No need to see us. Okay? But amiodarone can also cause profound hypothyroidism, something like TSH 60, T4 6, T3 undetectable. You straight away start them on thyroxine. And it can cause severe hyperthyroidism. We have seen this too many times, unfortunately. And if this type of results happen, you should really seek urgent help, because this could go wrong terribly. These people have already got ventricular or atrial arrhythmias. They may have ICD, they may have pacemaker, and they will decondition, and they go into heart failure, and they could even have a VF arrest and die. So really, we got to make up our mind, how do we treat, how long do we wait? And there are two separate subtypes. One would respond to ATD, other one needs steroids. And I think we are happy to help. I don't really want to say which one to do and all those things. We are happy to help, and this is a tricky situation. Occasionally, emergency thyroidectomy is needed to save their life. We have had quite a few of them over the years. Okay, next one. TSH 0.2, which is low. T4 is also low, 8. T3 is 3. Low TSH, low T4, T3. Differential diagnosis, sick euthyroid or hypopituitary. We discussed that earlier. Okay, check cortisol and pituitary function, and we are happy to help to work it out, whether it is sick euthyroid or something else. And you repeat them again, and if the pattern persisted, then you really need to work out what's happening here. Okay, this is a lady on thyroxine therapy. Let's have a look at it here. February 2023. TSH was perfect, 1.6. T4 was perfect, 16. T3 was perfect, 4.5. She was happy on Utroxig, 125 micrograms a day. She took it on empty stomach, no problem. Somebody decided to change the brand. Okay? Now, anyway, you don't know that. Somebody changed it. You did a blood test, TSH has gone up to 5. T4 has gone down a bit. Now, she says she's not keeping it in the fridge anymore. L-troxin, of course. And okay, you thought, okay, it's L-troxin, and I increased the dose to 150. Okay? Then she was happy again. Everything was normal. She was on L-troxin 150. You said, okay, continue. But then something happened in December. She came with a TSH of 25. T4 is low, T3 is low. She was on 150 of thyroxine. And you increased the dose to 200. She suppressed the TSH. She became toxic. What's happened here? Okay, too hard. I'll tell you what's happened is, she was on L-troxin, and here she got dispensed generic thyroxine. And chemist did not tell her. They are not the same. Right? So she forgot. She kept it outside the fridge because she has been keeping it outside the fridge anyway on L-troxin. How would she know that she should? This is my bread and butter now in endocrinology. Every day I see patients. First question, has there been a brand change? Have you kept this, which brand are you keeping in the fridge? First of all, you got to understand, L-troxin is not bioequivalent to Utroxig. Okay? Second thing is, patients keep it, some they keep it outside, some they don't keep it outside. It's a mess. So please pay attention and as far as possible, stick to the same brand because they're not bioequivalent. And patient must be told if L-troxin is not available, if you change to Utroxig again, you have to keep it in the fridge. Now, Utroxig and Oroxin must be kept in the fridge 2 to 8 degrees, but L-troxin and Levoxin can be kept under 25, not over 25, under 25. Okay? If you are traveling around Australia and you keep the thyroxine in a bottle in the car, it's probably going to go off very soon. And for her, L-troxin was not available, so this is all happened. Patient did not know, GP did not know, don't interchange the brands. Always remember, thyroxine must be taken on empty stomach half an hour before coffee, tea. And if you are escalating the dose, 150 to 200 is a fairly big jump. Very simple rule of thumb is you calculate the weekly dose, not daily dose. You look at what's their weekly dose, whatever they are on daily times 7, and then adjust 10% of that weekly dose at a time. Otherwise, you will overshoot or undershoot. It causes a lot of fluctuation in thyroid function test. And this is from the NPS website. They are flagging that Levoxin and Utroxig and Oroxin have similar bioavailability, but L-troxin does not because the way it is formulated, it has probably 10 to 15% less bioavailability. Okay? Okay. Right. I think we are coming to an end anyway. This one, patient has TSH 0.00, free T4 15 on thyroxine 100 micrograms. Hospital letter says she has had previous hypophycectomy. Choose the correct answer. Reduce thyroxine, stop thyroxine. These are all my experiences, by the way, that nothing is cooked up. Continue the same dose. I abstain from voting. Okay, last one. What do you do? Give me some answer.
You can't rely on the TSH.
Absolutely, thank you. At least that's what the message. Here, she had hypophycectomy. She had pituitary removal, so she does not secrete any TSH. So actually doing a TSH is a waste of money. Only do T4. Keep the T4 around 15. She's happy, we are happy. But I had a lady from long distance. I literally had to fight with so many people because every time the thyroxine was stopped because her doctor told her she does not need thyroxine, her TSH is suppressed. She had a big tumor cut out in the pituitary. Can be quite frustrating, so I had to write, nobody is allowed to stop her thyroxine. Because you do go into myxedema coma if you did that. Right. Now, this is the complicated pathway from Royal College of General Practitioners. Basically, everything what I said, TSH suppressed, T4, T3, do TSI, exclude postpartum, technetium scan, Graves versus non-Graves, and all this painless thyroiditis, painful neck, painless, too complicated. But if you get a brief understanding of what I'm trying to say, I think that's the objective achieved. So, final slide, learning points. Subclinical hyperthyroidism in older age group may result in atrial fibrillation, CCF, and osteoporosis. Therapy may be indicated. To differentiate etiology, TSI and uptake study. Ultrasound only if there is cold nodule or if the thyroid feels really nodular. Radioactive iodine is the preferred therapy for multinodular goitre. Remember to counsel antithyroid drug before you write a prescription. Please tell them that they have to go to hospital if they got fever, 39-degree, or severe sore throat. And importantly, pregnancy-associated mild hyperthyroidism does not need therapy, and usually postpartum thyroiditis revolves without any therapy. Hope it's been clear. Thank you. Oh, fantastic. I think they've understood everything.
Yeah, that's right. So, does anyone have questions? Great.
How far postpartum?
6 months.
6 months.
Typically, it is seen within 6 months of postpartum, but exceptionally rarely, it may occur up to 9 months. But if it is beyond 9 months, it's not postpartum thyroiditis. It's immune tolerance and immune intolerance. When pregnancy happens, there's a lot of immune tolerance happens. And when you come out of that immune tolerance, all these things will flare up and then they settle down. So it's first 6 months typically.
Over what time frame do people need to be anticoagulated before being?
I looked at that evidence because I'm writing a university module in a chapter. Typically, if we are giving electroverdioversion, it's 6 weeks. So I would go with the same period. If I'm giving radioiodine therapy, I would give minimum 6 weeks of anticoagulation before and after. After the radioiodine, until they come to euthyroid, and make sure that it's continued. And of course, it's not always hyperthyroidism causing AF. A lot of them have alcohol-induced atrial dilatation. They may have valvular disease. So you would need to do echocardiogram, get the cardiology consultation. But if nothing else is there, it's just a pure Graves' disease or hyperthyroidism, then that's what applies.
So one of the main takeaways is step away from the X-ray request form for a thyroid scan.
Well, I mean, use it judiciously. That's what I'm trying to say. I mean, hypothyroidism, we get ultrasound. Hyperthyroidism, we get ultrasound. I don't know whether Judy Lou is here, my colleague, and she wants to add to that.
You're making voices in the background. No, I agree. We do way too many thyroid ultrasound. Then we find things that worry us, that shouldn't worry us. And there's stick needles and things we don't have stick needles.
Yeah.
I was going to say, it's difficult though with AF, with hypothyroidism, we can treat, because leaving them untreated for 6 weeks when they've already got a dodgy heart. But I guess the point to be aware of the risk, and the other option is obviously to do an echo, make sure they don't have thrombus.
Yeah.
You could rate control on that, but they probably need much higher doses of all the
That's right,
Yeah.
that's right. So you've got time and their rate control, yes, you can do it. It's a bit like ambular and thyroiditis. It's difficult for us because there's a reason they're an ambular, right? They've got really bad hearts, and then we put them into thyrotoxicosis and they don't cope well.
And stopping amiodarone does not change the course. That's the other common misconception I forgot to mention. Once this is all happened, cardiologist stops the amiodarone. It's too late. Too late. I don't want you to stop amiodarone because that might even help the ventricular fibrillation. So we will work around amiodarone. Don't worry about that, we say.
What about if somebody's had a positive TSI in one month?
It could, yeah, it could.
Is there some guidance on when you would need to repeat it? Also, for our referrals, if they've got a suppressed TSH, like you have to have a TSI in there to get the repeats.
Yeah, probably that's for prognostication, but it may, there are a couple of things could happen. Most commonly, as after a couple of years, TSI will start disappearing, the load will start coming down, or it could start waxing and waning, and that's the hard one to pick up. And there is an extremely rare sub-variety of Graves which only comes during pregnancy. And again, it's actually Graves is meant to be easy in pregnancy. And I've come across with a series, and she was actually a colleague's wife. She had Graves only during pregnancy. TSI goes up, we all sweat, then it settles down postpartum. It goes up, then it settles down, something weird. So I think weird things can happen in medicine.
I think the point about mild gestational thyrotoxicosis is it's mild. It's rarely, the TSI is rarely going to be of interest. This is severe gestational thyrotoxicosis where it's a bit hard to say this Graves and it does happen to be pregnant or is this bad pregnancy, and that's where the TSI is helpful. And we care about it when it's 5 times the upper limit of normal, because that's when we start to see
Yeah.
fetal thyrotoxicosis. Unfortunately, for some people with Graves with very high T's, even after we treat them, they generally go down. But some women are so high that there was a one lady who was 10 years post-treatment and her Travs was still 50. So every time she got pregnant, we had to worry about fetal thyrotoxicosis, even though she didn't have thyroid and she had thyroxine. So they're the ones where prognostication.
Yeah.
A 22-year-old girl, I would do a TSI.
Yeah.
We said no treatment needed, and I want to know because she's not pregnant now, but she might be pregnant in 4 years' time. If that Trav is 40 now, she's not going to settle down for 2 years old. I control her for 12 months, but I can assure you, when you stop it, she'll
Yeah.
relapse.
Yeah. I mean, TSI is, it's harmless in other words, whereas in many ways ultrasound can be misled, and because it depends on the radiologist who interprets them. And now you have the classification of TRAD 1, 2, 3, 4, 5. And a lot of patients mistake TRAD 3 means it's stage 3 cancer. So you have to step back and explain to them that means these are the possibilities of cancer. Even TRAD 3 by no means is cancer. And even when you do an FNA, by no means it is definite. So it gets too complicated. Therefore, I shouldn't say this, but we tend to go back to Dr. McGrath for his expert advice. Now we have Dr. Chris Rowe and Dr. Emma Croker doing the same ultrasound. And because you have to really look at the films, you have to really look at all the reporting, and these days we have limited access to a lot of radiology because there are so many radiology, quality is an issue, and at the end of the day we have duty of care and obligation to the person in front to give them the best possible advice. So we will end up repeating a lot of these ultrasounds with Dr. McGrath, and he's going to give us a talk in November. Okay. Yes, please.
When I came in the door, I said, I see that the Diabetes Alliance program is now the program plus. Did you want to tell us a little bit more about other aspects of the program?
Okay, thank you so much for asking that. Okay, Diabetes Alliance was started back in 2017. We had only 3 full-time equivalent endocrinologists in the public. No way we could have seen so many people with diabetes. And then that's the time there was an opportunity to co-design and develop a new model of care with our GP colleagues. Margaret Lynch was involved from Charlestown. And we also had consumers, and then we came up with the model of care with Martha Parsons back then as well as the Alliance manager, that we would support primary care to deliver best possible care for diabetes by case conferences, data-driven performance appraisal, and master classes like this. So far we have been able to get to 170 GP practices. That's really good. And we have done around 5,500 case conferences. So the model of care is working very well. We have tracked the benefits for not only the patients who participated, but also the wider practice patients with diabetes. Then we were presented with a unique opportunity to go for a competitive bidding for a philanthropic funding just after COVID. And we submitted our proposal, and we were very fortunate to receive additional $12.4 million funding over 5 years. And that means we then partnered with not only the PHN, Primary Health Network, we brought the University of Newcastle and HMRI as our research and impact assessment team. So the vision is to expand Diabetes Alliance into rural remote parts of LHD, and we are the test bed for them, the funders. Everything is evaluated, the dollar invested versus the returns on investment. And if successful, which we have been so far, we have met all the objectives that was set out, there may be further scaling up of this program towards rural remote New South Wales. And in relation to that, we have developed an advice line for GPs, which is the 1300 I was telling earlier. And we do all the conferences, master classes to support GP community. During the advice line, we realized that half the calls were actually about endocrine, not about diabetes. I think diabetes, we have done very well to educate GPs now. I think they are very confident of prescribing and managing diabetes. But we then thought thyroid, osteoporosis, and calcium are the 3 big problems currently. So we have started this. And secondly, we are also working on a Medibus initiative for rural remote parts of our district, a bus that goes into rural towns, and that will have internet, satellite internet to connect specialists at our end. That is being worked out. And research modules have physical activity, nutrition, and mental health. And we are still in the developing phase. And the idea is to get the evidence, what is already known, published, and bring them into implementation. I think everybody knows evidence, but practicing that is very hard. We want to really look at those barriers and facilitate and enable that aspects to be implemented. And Michelle, we are thankful that she's one of our PHN advisor on that, so we run everything by her. So the work is going on. I think, you want to say anything, Martha?
I think the other, sorry, I've got croaky for some reason over dinner. The other 2 elements are that we're increasing our interaction with allied health as well. So we've now got a podiatrist and a dietitian on our team, and just looking at how we can improve access for patients across, particularly in the rural and remote areas, for those allied health services. That's I think, yeah, in a nutshell, I guess. If you go to our website's got lots of more information. Certainly if there's any practice that wants us to come and visit. We're nearly full for the year, but we do have cancellations at times. So if you start to put your expression of interest out, Sham, Judy, or the endocrinologists go out there and go to your practice and see patients with you and with the practice nurse. So, yeah.
And maybe you need to tell John Hunter's rapid response mainly.
Yes, sorry. Yeah, so a lot of the work that we've been doing is around improving access for patients, you know, depending on their acuity, of course. And when we started this, the wait list was quite significant, and just getting access for some of those really sick patients was really hard. So now what we've done is that patients will have access to rapid access at the John Hunter, and pretty much only rapid access, but what we've been able to do is offer these other opportunities. So advice line, for example, so patients aren't sitting on the waiting list for 8 months just to start insulin. Somebody can help you on the phone to get that started. We can send a diabetes educator out to your practice to teach your nurses how to teach patients if that's what's needed. So we've reduced the amount of patients being able to go to the John Hunter, but then what that's done is freed up our doctors to come out to you guys instead. And the virtual care. Sorry, thank you for your question. He was meant to say this.
The other thing we're doing that we didn't do in the original class is we realise that when we go out to primary care, we originally said we just look at type 2 diabetes, but we find so many unusual forms of diabetes and now
Yes.
technology, and there's a whole raft of type 1 diabetics who aren't coming to us.
I'm sorry, we can't hear you.
Sorry. I was just saying, when we originally started looking at type 2 diabetics, because that was within the realm of primary care, and we couldn't manage that, but we really recognise now that with technology, the number of type 1 patients in the community who aren't coming to see us in our specialist clinic, we've opened up with a pass to all diabetes, so you can pick, you know, people who have other forms of diabetes that they're struggling with, if they're not suited for John Hunter, they don't want to come.
You speak, yeah, you speak and tell about
Upskill, how to use a new technology, how to read the reports that the patients do now on the various CGM devices.
Thank you, Judy. So there is a virtual care option. So we would be, if you don't have so many patients for us to come to your practice, if you choose virtual care, we could organize telehealth case conference with the advanced trainee ourselves, diabetes educator at our end, but patient and GP has to be at your end. And that's actually a quicker way of getting patients seen. And it actually works much better for the patient because their GP participate. And that's Dishan runs that with the help of different specialists. And John Hunter, as Martha said, is now primarily for very high-end 30 days as the waiting list. Anything beyond 90 days, we go through a rigorous process of identifying which practice they belong to. And as soon as there are 5 to 6 patients belonging to one particular practice, it triggers us to contact you to say, hey, we will come to your practice for a day. And we see them. And the benefits are immense because patients don't have to travel. And as their primary GP, you take responsibility for those patients. And it saves us endless follow-ups. And it builds the partnership. And we know next time when Dr. Emma sends me a referral, I know she's done the alliance and I just need a phone call for her and vice versa. And that trust is very important. And that's what we really want to develop. Thank you.
I'd say as well, we had diabetes alliance in our practice today.
Oh!
Which was great. And I wasn't directly involved in the consultations, but I went in at lunchtime. So there's also another element where you have some of your data presented, and you can use that to develop your measuring outcomes for your CPD or to inform your quality improvement for your QI kit. So it makes those things quite simple as well. The other part that you didn't mention is about the it's a Medicare compliant
Yeah.
case conference,
Yeah.
which is really important. And as compared to something like, say, the psychiatry advice line, where GPs do that in their own time, there's no remuneration available for that. The Diabetes Alliance is doing case conferencing with the patient, so everyone hears the same information. You're getting that bit of backup, and you get to ask questions and learn, so that next time you can do it on your own. And but you're still billing Medicare. That was my attempt.
Okay, thank you. Okay, I'll hand over to Phoebe.
Thank you. Just a round of applause. Just great. I have no clinical background at all, and even I understood some of it. Thank you to everyone joining us online. We really do appreciate it. Thank you to everyone coming. We love putting these things on, getting everyone in the room and having these chats, and it's just amazing. For the people here, on your table you'll see a QR code that will take you to the evaluation for tonight. For the people at home, it will pop up on the right hand side of your screen. Again, thank you to everyone. Have a good night.